Welcome back, guys. Now we'll talk about cecal volvulus. Whenever there is cecal volvulus, I want you to understand that the patient will be young patient and patient will have recurrent episodes of abdominal pain, which are usually self-resolving. So there will be prior history of recurrent abdominal pain that is usually self-resolved. That is how the cecal volvulus will be present. Remember, cecal volvulus is an emergency because the patient is a young patient. So the diagnosis is CT scan must be confirmed. CT scan must be done in order to confirm cecal volvulus. Remember that. And treatment is as the cecal volvulus is emergency, it must be treated with emergency laparotomy, and you will have to do an emergency laparotomy immediately for patients with cecal volvulus. That is how I'll remember, because sigmoid volvulus can have risk factors such as constipation or patient will be an elderly patient, and sigmoid volvulus can. We talk about Next, we talk about mesenteric ischemia. We discussed in our previous lectures that mesenteric ischemia is nothing but angina of the intestinal tract. Patient who smokes so much will develop mesenteric ischemia. Remember, whenever there is increased workload to the gut cries. So the patient presents with abdominal pain. Whenever the patient eats food, the food must be digested. Whenever there is no blood that is flowing to the mesenteric or gut, there develops the nausea, vomiting, and then the patient develops abdominal pain. Whenever there is abdominal pain after food or after meal, that is when you will have to think of mesenteric ischemia. The most common important risk factor for mesenteric ischemia is smoking. Whenever there is smoking, whenever there is abdominal pain after food, usually the examiner gives you that the patient will have aversion to the food because the patient develops abdominal pain after having food. That is why patient will not eat food. So you'll have to remember that whenever there is abdominal pain after meals, you'll have to think of mesenteric ischemia. Whenever there is mesenteric ischemia, it is the periumbilical pain that is out of proportion to the clinical examination findings. That is when you'll have to think of mesenteric ischemia, please. The patient will present with leukocytosis. The patient can present with elevated amylase and phosphate levels as well. Usually, there is metabolic acidosis on VBG that is usually seen, but remember, the CT angiography is the investigation of choice for mesenteric ischemia because we will have to identify that the vessel supplying the mesenteric or mesentery is basically stenosed. That is what we'll have to identify on CT angiography. Remember, the treatment is you must not give anything. It is the IV fluids, it is the nasogastric decompression that we will have to do. All right. Next one, we talk about inflammatory bowel disease. We discussed so much about inflammatory bowel disease in medicine. We will discuss what is essential in surgery. Whenever there is inflammatory bowel disease, it is the complications that patients usually present with in the exam, and examiner will be keen to test the complications. What is the first most important complication of Crohn's disease? It is the fistula formation that is usually formed. It is the stricture that is usually formed. In ulcerative colitis, it is the toxic megacolon that is usually formed. Whenever the patient presents with the fistula, it is the continuous drainage we usually see. Whenever the patient develops abscess, it is the fever that is present. Whenever the patient develops strictures in Crohn's disease, we discussed intestinal obstruction and small bowel obstruction of in Crohn's disease with the strictures. That is how patient presents with. Whenever talking about ulcerative colitis, it is the toxic megacolon that is usually seen. And we discussed a lot about the non-caseating granulomas in Crohn's disease, no granulomas in ulcerative colitis. It is the mucosal involvement in Ulcerative colitis, it is the pseudo polyps that are formed in ulcerative colitis. It is the cobblestone appearance that is seen in Crohn's disease, and Crohn's disease can involve any part of the intestine from mouth to anus. Whereas ulcerative colitis, it is the rectum that is usually involved. It is an ulcer, so it can spread. So continuous lesions are usually seen. Talking about the most important complication of ulcerative colitis, it is the toxic megacolon. Whenever there is a dilation of the colon in patients with ulcerative colitis, you will have to think of toxic megacolon. Patient usually are toxic, so patient will be having fever, patient will present with the tachycardia, and there can be diarrhea. Next, in the question, whenever there is toxic megacolon, patient presenting with fever, tachycardia, and diarrhea, patient will have history of ulcerative colitis, or patient can also have history of hypotension. Patient can also have a history of admission to ITU or critically ill or underlying medical disorders where the patient can be developing toxic megacolon. The first most important thing you will have to rule out for toxic megacolon is if the patient has got any infection or not. Diagnosis, first best investigation of choice is an abdominal X-ray where you will find that the patient has got a dilated colon of more than 6 centimeters. It is usually the transverse colon that we check the diameter, and that is more than 6 centimeters. Sometimes there can also be multiple air fluid levels as well. The treatment for toxic megacolon is IV fluids and broad spectrum antibiotics. You will have to advise the patient not to eat anything by mouth. It is the bowel rest that we will have to use. Whenever the patient has got a history of IBD or inflammatory bowel disease, it is the IV corticosteroids that we will have to give. Whenever the patient has got Clostridium difficile infection, no IV corticosteroids are given, please. IV corticosteroids must not be given if the patient has got Clostridium difficile infection because there can be risk of rupture. Next, we talk about erythema nodosum and inflammatory bowel disease. One of the most common complication or one of the most important association of skin findings in IBD is erythema nodosum. Erythema nodosum can also be seen in patients with sarcoidosis and malignancy. But remember, erythema nodosum in Crohn's disease, you will have to identify that the patient develops abdominal pain with the diarrhea and then skin lesions. It is erythema nodosum. Whenever there is erythema nodosum, it is a tender lesion. It is a non-pruritic lesion. You will have to do a biopsy of the nodule. You will have to do a biopsy of the erythema nodosum, which shows septal panniculitis, but this is not a vasculitic rash. Very important for step one examination, please. Next, I want to talk about indications for colonoscopy. First, most important indication for colonoscopy is screening for colon cancer. Whenever there is Next, we talk about indications of colonoscopy in inflammatory bowel disease and in normal patients. Whenever we are doing a colonoscopy, it is basically a screening tool to rule out or to diagnose or to make sure that there is no colorectal cancer. Patient who has got profuse rectal bleeding, they must be screened with colonoscopy. Patient who are at high risk of colorectal cancer, such as patients with inflammatory bowel disease, patients who has got a family history and has got a age of 40 to 49 years, they will have to undergo colonoscopy, please. And annual colonoscopies must be done in patients with primary sclerosing cholangitis and also patients with inflammatory bowel disease. Next, I will talk about constipation. Whenever I talk about constipation, the alarming features of constipation is important. Please remember that the most important step you will have to do for a delirium patient with who has not opened bowels for more than 2 days is an abdominal image, please. There will be soft tissue opacities with the internalization of the air. That is what you will have to think of because the intestine is loaded with feces. Whenever you think of alarming features of constipation, it is basically The weight loss, it is basically patient age more than 50 and patient has got a family history of malignancy or an inflammatory bowel disease. These are the most important alarming features of constipation. However, if there is weight loss, that is always an alarming feature in any of the conditions. Next, we talk about anal and perianal mass. When I talk about anal and perianal mass, I'll share you the screen. Give me a minute. Whenever there is anal mass and perianal mass is what we are talking. Whenever there is anal and perianal mass, you will have to differentiate between those masses. First thing is external hemorrhoids. Whenever there is external hemorrhoids, the patient usually think that the patient has got a mass whenever he is washing his toilet. Whenever there is external hemorrhoids, patient can also complain of itching and there can be painless bleeding. Sometimes whenever there is pain in the external hemorrhoid, it is the thrombosis or it is an acute presentation of a thrombotic external hemorrhoid that usually presents with the pain. Next, we talk about internal hemorrhoids. Whenever there is internal hemorrhoid, it is a painless bleeding that the patient develops with the leakage of stools. Whenever internal hemorrhoids are present, it is detected with the digital rectal examination or it can be diagnosed with anoscopy as well. Whenever there is perianal abscess, please do think of fever, please do think of inflammatory bowel disease. And whenever there is perianal mass, it is a fluctuant mass and there can also be erythema as well. There can be swelling, there can be erythema as well. Next, we talk about another mass called anogenital wart, usually seen in young patient because of the HPV infection. It is basically presenting with mild itching and bleeding. Very important in the question. This is what they give you on examination. There is a cauliflower shaped mass in the or surrounding the anus. That is what you will have to think of. That is when you will have to think of anogenital wart. Next, we talk about anorectal cancer. Whenever there is anorectal cancer, it is the squamous cell carcinoma that is usually most common and patient presents with an ulcerating mass or an enlarging mass that you will have to identify, please. The treatment for hemorrhoids is basically conservative management. It is usually the sitz bath that we usually advise the patient. And you can also do surgical management for internal hemorrhoids. It is the rubber band ligation or infrared coagulation or sclerotherapy. Remember, sclerotherapy is what they usually give, but now infrared coagulation is also given in the options. Whenever there is an external hemorrhoid, it is the surgical management with hemorrhoidectomy that we will have to do as a management for external hemorrhoids, please. Sometimes if the patient has got pain, you can use benzocaine as well. Next, we talk about first most important management for hemorrhoids is high fiber diet. That is what I will think of. Next, we talk about the perianal abscess. We briefly discussed you'll have to identify that there is fever. Whenever there is fever, whenever there is perianal abscess, it is the incision and drainage with the systemic antibiotic coverage is what you will have to think of. Very important. Next, whenever there is systemic antibiotic therapy, you will have to think that the patient will have decreased recurrence and patient will also have the decreased chance of forming a fistula. That is why we use antibiotics in patients with perianal abscess. Next, pilonidal sinus. Whenever there is a driver, whenever there is a young male, whenever there is a obese male who is not exercising and has got a sedentary lifestyle, and whenever the patient has got a deep gluteal clefts, they will have to think of pilonidal sinus, please. Whenever it is a sinus, it is because of the compression. The patient can have a painful fluctuant mass usually in the intergluteal region. That is when you will have to think of piloneedle sinus. The treatment is drainage of the sinus, and you can also do an excision of the sinus tract. One of the most important differential diagnosis for piloneedle One of the most important differential diagnosis for pilonidal sinus is hidradenitis suppurativa. Whenever there is hidradenitis suppurativa, the patient will be young patient, the patient will be a smoker, the patient will have foul smelling, fluctuant and drainage of the sinuses in the axilla or in the flexural areas. Sometimes there can also be nodules that are usually formed. In hidradenitis suppurativa, it is a recurrent painful nodule that is usually present, please. Next, we talk about anal fissure. Whenever we talk about anal fissure, the first most important thing is patient will present with pain. So please do not do a per-rectal examination. Whenever there is anal fissure, the stem or the question mentions the patient has got inflammatory bowel disease, the patient has got constipation. What is the thing you will have to identify in the question? It is basically the posterior anal midline that is usually affected. There can be chronic fissuring of the anal fissures. The treatment for anal fissures is high fiber diet. Make sure that the patient is not dehydrated. Make sure that you correct the constipation by using stool softeners. Make sure that the patient has been prescribed topical anesthetics and vasodilators as well. Remember, nifedipine is one of the options you will have to choose in patients with anal fissure. Very important. Next, we talk about radiation proctitis. We talked about this in medicine. Whenever there is radiation, whenever there is history of malignancy, whenever the patient is undergoing radiation, the patient will develop inflammation of the rectum. Whenever there is inflammation of the rectum, whenever there is radiotherapy, there can be direct mucosal damage or there can be affected arteries that are supplying to the rectum. Whenever the arteries are affected, it usually takes time. Whenever the arteries are affected, the arteries are obliterated. Whenever the arteries are obliterated, whenever the arteries are affected, it usually causes decreased blood supply to the rectum. Whenever there is decreased blood supply to the rectum, it is the mucosal ischemia that develops. And remember, the natural course of healing is formation of fibrosis. So there will be submucosal fibrosis. In order to form submucosal fibrosis and in order to involve the arteries, it takes time. Whenever there is mucosal ischemia of the rectum and whenever there is submucosal fibrosis, it is the chronic radiation proctitis that we are talking about. Remember, whenever there is chronic radiation proctitis, there will be neovascularization that will be formed in order to make sure that the blood supply is achieved to the rectum. So there will be multiple telangiectasia on endoscopy. Whenever there is multiple telangiectasia and whenever there is mucosal pallor or mucosal ischemia, you will have to think of chronic radiation proctitis. The first most important management for chronic radiation proctitis is endoscopic thermal coagulation in order to make sure that the telangiectasia are removed. Whenever we talk about acute radiation proctitis, it is acute, so it is the rectal mucosa that is damaged. So acute radiation proctitis usually presents within less than 8 weeks. Remember that the endarteritis or the ischemic changes have not been developed in acute radiation proctitis. Whenever there is manifestation or clinical features, the examiner mentions that there is diarrhea and there is mucosal discharge in acute radiation proctitis. Whenever there is mucosal damage, whenever there is mucositis on clinical examination or on endoscopic examination, it is the erythema, it is the redness, it is the ulceration you will find in acute radiation proctitis. On endoscopy in acute radiation proctitis, there will be erythema, there will be mucosal damage, there will be mucositis, there will be ulceration as well. The management will be antidiarrheals because diarrhea is the most common symptom in acute radiation proctitis. Coming to or talking about chronic radiation proctitis, it is chronic. Whenever it is chronic, there is time. So there will be formation of stricture. That is what you will have to remember in patients with chronic radiation proctitis. That is why you will have to do an endoscopic thermal coagulation as well. Next, we talk about anorectal fistulas. The most common complication will be a Crohn's disease patient. So, young male or young female with history of Crohn's disease, there will be history of malignancy, there will be history of radiation exposure. That is when you will have to think of anorectal fistulas, please. Whenever there is anorectal fistulas, there will be pain and there will be palpable fistula tract as well. Whenever there is the management that is asking whenever the examiner is asking about the anorectal fistula management, you will have to make sure that the fistula is first diagnosed. Remember, in medicine and surgery, it is the MRI or the fistulogram that is the confirmatory investigation of choice for anorectal fistula. You will have to do surgery, that is fistulotomy for anorectal fistula, please. Next, we talk about colovesical fistula. Whenever there is colovesical fistula, the urinary bladder is affected. So the air from the gastrointestinal tract is entering the bladder and there will be air in the urine that is called as pneumaturia. Sometimes the stool can also enter the urinary bladder and that is called as fecal urea. Remember, whenever there is a fistula formation, the most common risk factor in surgery or for USMLE is chronic disease, and patient can also have malignancy who has underwent radiation. So pneumaturia or air in the urine or stool in the urine, or whenever there is recurrent urinary tract with infectious organisms which is suggestive of bowel, that is when you will have to think of colovesical fistulas. The diagnosis for colovesical fistula is abdominal contrast CT scan. Basically, the abdominal contrast is usually given by oral route or rectal route, but it is not the intravenous contrast. It is CT with the oral contrast that you will have to select whenever there is colovesical fistula. Next, I want to talk about rectal prolapse. Talking about the rectal prolapse, it is usually a female patient with the age more than 60, patient with prior pregnancy, multiple pregnancies, patient with chronic constipation, patient with pelvic surgeries, patient who has developed abdominal discomfort and there is mass on evacuation, or there is fecal incontinence, or there is recurrent urinary tract infections. That is when you will have to think of rectal prolapse. Whenever we talk about rectal prolapse, it is the medical management that we usually do. It is the medical management that we usually do. You will have to consider adequate fibers and fluid that needs to be ingested first. Next, we talk about the pelvic floor exercises, and sometimes biofeedback for fecal incontinence can also be done. But remember, whenever the patient has got a full thickness prolapse or whenever the patient has got a symptomatic prolapse, you will have to do surgical procedures in patient with rectal prolapse, please. Next, I talk about Clostridium difficile diarrhea. Remember, the Clostridium difficile diarrhea is usually seen with recent antibiotic use, patients who are admitted to the hospital, or patient who has got a increased WBC count. That is when I will think of Clostridium difficile diarrhea. I want you to understand, whenever there is watery diarrhea or abdominal pain and low grade fever, you'll have to think of Clostridium difficile diarrhea with recent antibiotic use, recent hospital admission, and advancing age. The first most important thing you'll have to think of Clostridium difficile diarrhea is whenever the patient has got a raised WBC count. The complication of Clostridium difficile diarrhea we discussed is toxic megacolon. One of the most important treatment for toxic megacolon is usually an antibiotic therapy, which is associated with the Clostridium difficile diarrhea. But if toxic megacolon is associated with inflammatory bowel disease, it is the steroids that we usually give. Remember, see, Clostridium difficile diarrhea associated toxic megacolon, we will not give corticosteroids because there will be increased risk of perforation in patients with Clostridium difficile diarrhea, and examiner would love to test this. Remember, patient with fever, hospital admission, recent antibiotic use, now developed the distension of the abdomen which is tender. Think of Clostridium diarrhea, please. Next, we'll talk about hernia. I'll send you a new link and then we'll meet there. Thank you very much.